Welcome, this is Dr. Brian Buchanan from the Department of Critical Care Medicine. We'll talk about high-quality acquisition interpretation for the critical care ultrasound examination. I want to cover some basic machine operations. We'll cover this for the edge and the export from Sonosite. Now again, there are other machines, and these buttons are roughly equivalent. So gain is gain no matter what kind of machine you use, and so is depth, and so are your settings like M mode, color, two-dimensional ultrasound. I cover these machines because they're the most common and likely to be populating all of our ICUs across Edmonton as we slowly phase out other models. I want to cover the acronym orientation, depth, angle, and gain, as this is really key to understanding acquisition interpretation. First off, orientation. We talked about this a lot, but I really highlight this to emphasize the differences in your acquisition technique. Now, this really depends on the exam type you choose. This will be set automatically. This can be changed manually, but really I would just encourage you to use the machine settings. In the export, we can use the probe selection screen to choose the exam type, as shown here. Transducers and exams. This brings the probe dialog menu up from the HFL 38 linear, P21 phased array, and C60 curvilinear. Once your setting is chosen, if you press scan on the left, it will automatically go into that mode. Now again, you must consider the anatomical plane of the image, whether it's in sagittal, coronal, or transverse. The coronal plane is the most common one used for imaging of the pleural effusion, for example. In this case, the screen marker is left for traditional imaging, and cephalad is also image left, as shown here. The peristaltic long axis image acquisition is a touch different because again it refers mostly to the anatomical position and to the axis of the left ventricle. The peristernal short axis really refers again to the peristernal placement of the probe, but also the short axis of the left ventricle. The short axis acquisition technique really falls very closely to the perisagittal plane. Labeling can go a long way to help you describe your images and demonstrate them for later review. In this case, labels press. Now we can either use the standardized text or we can actually type it in. Even easier is to really use picto, shown here. If you select one of these torso or organ types, it'll display on your touch screen but also on your main imaging screen. It also have a probe which you can move to adjust on where you're acquiring the image from. This will help you and us as quality assurance examiners understand where this image is being acquired from. Next is depth. Again, on the Sonosite Edge, you can see depth is shown here to either increase or reduce your depth. On the export, we can see this is manually adjusted on the screen right. How much depth you have permitted will depend on the exam type you choose. In this case, we can see some adjustments here made in real time, starting off 15 centimeters and reduced, as the chest wall should be collected around 6 to 10 centimeters. This allows us much better visualization, but also much more confidence for you. In this case, this will be for lung ultrasound, looking for pleural sliding in A lines, as shown here. The white arrows lung sliding, and your green arrows are recurrent A lines. That's a reverberation artifact. Now turning towards depth settings, this is a peristaltic long axis image. We can see here that on image left, we have a reduced depth, and we do have really strong visualization of the peristaltic long axis structure. However, the depth should be set a little bit deeper initially. On image right, we can see that there actually is a pleural effusion. Not only that, we see that mirror image artifact in the far field where there is an artifactual beating heart. So I would encourage you on most views to start a little bit deeper and reduce the depth to optimize your screen real estate, but not to forget that things can hide beside other organs. In this case, we can see again that if we don't adequately address the depth initially, we can easily miss pleural effusions, but you can also miss pericardial effusions. That's why it's important to turn attention to this when you approach any exam. In the posterior thorax, we aim for about 12 to 18 centimeters. What I really want to see is the posterior spine, as this gives us a sense of the anatomical orientation and acquisition. Again, we can see here that cephalad will be screen left and caudal, or towards the feet, will be screen right. Angle, this really refers to the position of your acquisition and how the probe is held. In this case, we can see this is the pleural space. This is flapping atelectatic lung. But we don't see the diaphragm well, and as someone providing quality assurance, I may actually be challenged by an image like this, as there are other structures in the body that can look very much like the lung, including the spleen. The ideal way to capture this is to make sure you capture the entire anatomical space, including the diaphragm, the chest wall of the lung, and the subdiaphragmatic viscera. So the aim is to have the diaphragm fall roughly in the middle of the screen. This is also true for the parasternal lung axis. We can see here that the rocking has led to an off-axis image initially, but then corrected to bring the mitral valve roughly in the middle of the screen. The LV is pointed up here, and I can tell you this view is likely acquired very low on the sternum. A more conventional view would be this. This is the ideal view, obviously quite challenging to obtain, but you want to have the mitral valve fall roughly in the middle of the screen. You're interested in the base and mid portion of the LV and not so much in the LV apex at the parasternal lung axis. And so this would be the ideal angle to obtain this view. Again, this is the rocking example which displays how this lung axis view is obtained to ensure it's on axis. Finally, gain. Again, there's no real way to set the ideal gain, but there is gain that's too low and gain that's too high. I'd use fluid-containing structures as your standard to set it. That way you can adequately hone your image. You can see on the left, appropriate gain where there's good endocardial resolution and good definition between hypoechoic, hyperechoic, and anechoic. And on the right where it's too white and leads to an increase in noise over signal. Also, again, with reference to near field and far field, some machines will have these slider buttons which can adjust the gain depending on the level. I would most often defer to auto gain, or occasionally will be a global slider gain button, which I would use as a more simpler technique. Here is a Sonoside Edge keyboard. We can see that, again, here's that time gain compensation. That's that gain at depth, a global gain button, and auto gain button. On the export screen, we can see this global slider button for gain. As this is moved, it reveals near field and far field gain buttons. There's also an auto gain button which you can press in general too to help enhance this. Taking clips and still images. To take a clip is defined as a 3 to 6 second prospective or retrospective clips. Currently, most machines are set prospectively, but this can be easily reset. Freeze simply freezes the image. Clip activates the machine to record a 3 to 6 second prospective video clip depending on your settings. You must press save to capture a still image or capture a clip. And once you press end exam, this will be stored to the machine repository. With the export, this is processed a little bit different. There is a freeze button and there is a save video clip, but this will enter into a different mode. With the export, to save an image clip, you will press save video clip, which will initiate a 6 second prospective series. Now, after the 6 seconds is concluded, it will show this image. You can scroll back and forth with this button to use the cine function to allow you to examine an individual image. As we can see here, this is adjusted back and forth. We can also clip the image for a specific slice of this overall clip for a smaller portion. You must press save at least twice to actually save the image to a repository. Now, once end exam is pressed, these clips will be stored. And unless you have a patient name plugged into your system, this will be stored anonymized. So you can either enter the patient name before the exam is initiated, or even after the exam is initiated before you press end exam. So again, just a key thing here is save video clip must be pressed twice, and if you want a still image, you press freeze and then press to save the image. So in summary, we covered orientation, depth, angle, and gain. Again, I'd ask you to look at your screen marker, probe marker, and imaging plane. Ask if the depth is optimized. Look at, is this a standard imaging plane, like for looking at the diaphragm, the pleural space, or the parasternal lung axis? And then finally, do you have good tissue resolution and good margins? Is fluid black? So there are your basic machine operations. This can be used for really any machine. It's just many of the point-of-care machines are adjusted to be a little more user-friendly. but these same principles are ones used for the big IE33s, or big echo machines you see being hauled around. I'd like to thank you for listening, and I hope you found this informative.